Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. All right, great. Welcome to the Rational Wellness Podcast. I'm Dr. Ben Weitz, and today we're joined by Dr. William Davis, cardiologist and New York Times bestselling author of a number of books, including Wheat Belly and Super Gut. And his newest book, Super Body, Dr. Davis shifts the focus from gut and grain to body composition, muscle preservation, and metabolic rejuvenation. He challenges the calorie-in-calorie-out model. He critiques the widespread use of GLP-1 agonists in bariatric procedures. And he argues that muscle tissue and the microbiome are the keys to restoring youthful vitality and metabolic health. We'll dive into the mechanisms behind this, the practical strategies, and what clinicians can take away to better support patients seeking to improve muscle mass, metabolic resistance, and long-term body composition. Dr. Davis, thank you so much for joining us.
Oh, my pleasure. Glad to be here.
Okay, great. So, when I read that the focus of your book was that people who lose weight often lose muscle, and that preserving muscle mass and losing visceral fat was the goal, I thought, when I read your new book, Super Body, you'd be talking about doing heavy weight training, eating lots of protein, maybe taking whey protein powder or amino acids or creatine, but you don't discuss much of that. I was surprised. Can you explain how you... Yeah, go ahead.
I want to go beyond the conventional ideas. Conventional ideas have kind of gotten us in this mess. That is, what's surprising is the science has advanced considerably and shows us that conventional methods of losing weight, whether it's a reduced calorie diet, some of these branded programs, for instance, or as our colleagues like to say, move more, eat less, or smaller portion sizes, or it could be a bariatric procedure like lap band or gastric bypass, or it could be even a pharmaceutical, like the very popular GLP-1 agonists that reduce appetite. Well, these are all variations on the same theme. They all cause a reduction in calorie intake. So GLP-1 agonists, for instance, make you indifferent to food. And
by the way, for those who are listening who don't know what GLP-1 agonists are, those are drugs like Ozempic, which a lot of people are using for weight loss right now in the United States.
Mm-hmm. So they work. These methods do work in the near term to cause weight loss. The problem is other things happen besides just losing fat. So one of the problems is that of the weight you lose, approximately 25% is muscle, whether it's low-calorie diet, bariatric procedure, or a pharmaceutical. You lose 25% of the weight loss is muscle. So if you paid, for instance, $12,000 for a year's worth of one of those GLP agonist drugs, and you lost 40 pounds, which is very common, of that 40 pounds, 30 pounds is fat, 10 pounds is muscle. Now think about 10 pounds of muscle, of course, on 10 pounds, say, of ground beef on your kitchen counter. That's a lot of muscle. Well, if you stop the drug, which is very common, most people either can't afford it forever or they have intolerable side effects. You stop the drug, you typically regain about 32 to 34 pounds of fat, mostly in the abdomen, and you don't regain the muscle. You regain maybe a trivial quantity of muscle. Well, your blood glucose, your blood pressure, your inflammatory markers are all worse now, and you're much more likely to be a type 2 diabetic or pre-diabetic, have hypertension, risk for coronary disease, risk of dementia, heart. And because Oops. Okay. Did I lose you?
You broke up a little bit, but go ahead.
Okay. Okay. Uh, when you lose that much muscle, we know with good science now. A lot of this work was, they showed that when you lose that much muscle, your basal metabolic rate, that is the rate at which your body burns energy for the work of life, breathing, digestion, etc., your your basal metabolic rate drops, typically about 25%. And that means you need fewer calories to stay alive. And if you stay on a low calorie diet and an intensive exercise program after you lost the weight with one of those methods, you will regain the weight. I had a very nice conversation with Danny Cahill.
Okay.
He was the winner of the 8th season of The Biggest Loser TV show.
Right.
So he lost 239 pounds. Astounding, right? And breathtaking amount of weight, 239 pounds in 7 months. He looked terrific, though the graduates typically are wearing Spanx underneath their clothes because they have such awful loose skin flaps. But nonetheless, he wins the program. He wins the contest. He gets the $250,000 prize. And I talked to him now some years afterwards, and he's regained all the weight. He told me he left the program. This is a serious guy with a very deep commitment to maintaining his weight. He left the program, maintained a 2 hours per day, 6 days per week exercise program, resistance and aerobic, and a low-calorie diet. And he regained all the weight. And he said he'd go back to the annual reunions hosted by the producer's TV show, and he saw all the other graduates going through the same thing, all regaining the weight. And when I talked to the guy, he was clearly beaten down, demoralized because he regained all the weight after all that fanfare. Now, the NIH scientists studied his class of graduates of the program and measured their basal metabolic rate both at the completion of the program and 6 years later, and their basal metabolic rate stayed much lower, even 6 years later. So it's, for all practical purposes, a permanent effect. And it guarantees that you will regain the weight as fat, not as muscle, but as fat. You're worse off now even worse. I'm always impressed that there have been groups who did this. They took tens of thousands of people and tracked them after they lost weight for several years, up to 20 years. So there are several large databases in which this was done. The NHANES, the NIH's database, the Western Europe Epic Norfolk database, the ASPRI database, in total over 60,000 people followed for many years. What happens to those people who lose weight? Well, the people who lost 10% of their weight or more. So a woman who starts at 180 pounds loses 18 pounds. A guy who starts 240 pounds loses 24 pounds. This is not pretty common stuff. They're going to die several years younger. And their last few years are much more likely to be spent in assisted living or other facility. They're much more likely, they're more prone to falls, fractures, frailty, sarcopenia, loss of muscle, loss of independence, and dementia. And then they die several years younger. This is what the drugs and all those efforts at cutting calories, the science is now clear. It is you set a bunch of landmines for your life when you lose weight by cutting calories, largely because the loss of muscle and the reduction in the basal metabolic rate.
So I would argue, and we've argued for many years, is that that's why you don't want to lose a lot of weight quickly. You want to do it slowly. You want to make sure you're incorporating heavy weight training and adequate protein levels. And if you lose at the rate of, say, maybe 1 to 2 pounds a week or so, you can maximize the amount of fat loss while minimizing the amount of muscle loss.
So the studies tell us that should you incorporate resistance training with your weight loss efforts? So yet again, another very excellent NIH study. So if you lose let's say 25% of your basal metabolic rate when you lose weight. If you incorporate strength training, you lose about 18% of your basal metabolic rate. It reduced. In other words, it blunts it. It does not avoid it. And so
even if you lose weight slowly and you include adequate levels of protein?
So once again, you blunt it. You don't prevent it. So all you can do with those kinds of strategies, because there's too many factors that are working against you. For instance, a very, very common problem I'm sure you run across in your practice is SIBO, is small intestinal bacterial overgrowth, and thereby endotoxemia, meaning there's wild overgrowth of fecal microbial species because of our overexposure to antibiotics and other factors. That starts in the colon. These overproliferated fecal microbes then ascend into the 24 feet of small intestine. And the small intestine is not accustomed to this. It's very permeable by design because that's where we're supposed to absorb nutrients like amino acids, vitamins, and minerals. But when you have the infestation or colonization of the small intestine by fecal microbes, and it's not equipped to deal with it, it increases the permeability even more. And when those microbes, trillions of them, die, they release their toxic compounds, but specifically components of their cell wall, endotoxin. And that endotoxin is released into the intestines and then into the bloodstream, a process called endotoxemia. And we know with good evidence that endotoxemia is a major factor that damages muscle. So in other words, if you lost weight fast or slow, regardless of method, but you have endotoxemia working against you, you will not maintain muscle because it's damaging your muscle. How common is this? Well, it's half the country. It's huge. That's not being talked about, but the science is already there. In other words, all I did, for instance, was ask this. Let's look at the several dozen studies that asked this question. In condition blank, what proportion of people will test positive for SIBO? Usually by hydrogen gas breath testing, some other methods.
Right.
So let's put in
SIBO breath testing is pretty much the only way to determine SIBO, right?
That and duodenal aspirate, but no one wants to do that.
Right. Yeah.
An endoscopy. Yeah.
Right.
So let's insert into the blank irritable bowel syndrome. So there's 60 to 70 million Americans with IBS. What proportion test positive? Well, it varies from study to study, but on average, about 31%. Well, that's about 18 to 20 million people right there. How about we insert obesity into the blank? Well, that's 110 million Americans right there. What proportion tests positive for SIBO? About 50%. So that's about 55 million people right there. Well, let's add up all the people who test positive with fibromyalgia, type 2 diabetes, prediabetes, sleep apnea, rheumatoid arthritis and other autoimmune conditions, neurodegenerative conditions. In other words, you'll see you can rapidly exceed easily 100 million and more likely more than 150 million people in this country, about 1 in 2. And I didn't believe it at first. Even though the math told us that was true, I didn't believe it. Till I started testing people. There's a consumer device. I'm in a hotel right now. I'm not at my desk. Call my Air device, AIRE. It's a consumer device.
Yeah.
That allows people to test for hydrogen gas. It's a mapping device. It helps you map where fecal microbes are living in your gastrointestinal tract. And to my great surprise, as I had thousands of people doing this, huge numbers tested positive. And it correlated with whatever condition they had, sleep apnea, fibromyalgia, whatever. Then we corrected it. And I saw all those problems go away. If someone hit a weight loss plateau, for instance, it would break with correction of the SIBO. If they couldn't build muscle, they would build muscle because you reduced the endotoxemia. If you had high blood glucose, wasn't coming down, it finally came down once you addressed the SIBO and thereby the endotoxemia. So I became convinced that this is far more common than we think. And among the consequences is, so if you have endotoxemia that's not addressed, you will expand abdominal visceral fat and you will impair muscle. including, by the way, the deposition of fat directly into muscle. That's becoming a big problem, by the way, so-called myosteatosis. That is, as you accumulate fat in the abdomen, which is very common and underappreciated, you will in parallel deposit fat in muscle, myosteatosis. And that impairs muscle function, muscle strength, and impairs what's called myokine production. That is, muscle is, muscle, we thought from years muscle was this inert thing, right? That allows you to walk and climb, that kind of stuff. But no, it's actually an endocrine organ that produces numerous factors that impact brain health, bone health, gastrointestinal health. Muscle talks to your gastrointestinal microbiome and vice versa. And so one of the effects of myosteatosis and endotoxemia, those processes, it not only impairs muscle, it impairs myokine production, and thereby yet another layer of interfering with muscle metabolism. And so, in other words, if all we do is lose weight, you have not addressed many of the factors that are impairing multiple aspects of health, but also muscle health.
I've really been enjoying this discussion, but I just want to take a few minutes to tell you about a product that I'm very excited about. Imagine a device that can help you manage stress, improve your sleep, and boost your focus, all without any effort on your part. The Apollo wearable is designed to do just that. Created by neuroscientists and physicians, this innovative device uses gentle vibrations to activate your parasympathetic nervous system, helping you feel calmer, more focused, and better rested. Among the compelling reasons to use the Apollo wearable are that users experience a 40% reduction in stress and anxiety. Patients feel that they can sleep. Their sleep improves up to additional 30 minutes of sleep per night. It helps you to boost your focus and concentration. And it's scientifically backed. And the best part is you can get all these benefits with a special $40 discount by using the promo code Weitz, WEITZ, my last name, at checkout to enjoy these savings. So go to Apollo Neuro and use the promo code Weitz today. And now back to our discussion. Dr. Pimentel has said that trying to use that food marble device to diagnose SIBO is not really accurate because what's been correlated with testing the samples is having the patient drink the lactulose and then timing the breath test every 15 minutes and not just eating a meal and checking the breath.
That's right. And I have great respect for Dr. Pimentel's work. He's done a lot of great work, but I think he's wrong on that issue. There have been validation studies on the Air device. I have no relation with the Air device, so I'm not defending it, I'm selling it or something. But it's been validated in 2 studies to be as good as or better than getting hydrogen gas testing in a lab or clinic because it's a point of contact. In other words, if you were to collect breath in a bag, a tube, right, or a canister, hydrogen gas is a very small molecule and it's prone to leak, even if you're really quick about capping your tube or whatever. The Air device is direct contact. And so I think it's actually at least as good and probably superior. And no one's advocating that we test randomly after a meal. That doesn't work because that's going to measure colonic fermentation or production of hydrogen gas. So what we do is there is a prep, just as you would. There's a diet prep at 12 to 24 hours, avoiding all fibers, sugars, and alcohol. And then you do a baseline and you consume something that most microbes that cause SIBO consume. Now, they use, as you point out, lactulose in the lab, which I think is a mistake because we use inulin, because inulin is metabolized by a greater number of species that characterize SIBO. In other words, if you consume something like lactulose that many microbes can't convert to hydrogen gas, you're going to miss that. that rise in hydrogen gas. So we use inulin because it's more widely metabolizable. Now, we like to do some formal studies to validate all that, but we already know with science, with multiple experiments, that inulin is widely metabolizable by microbes.
Interesting. What form do you get the inulin in?
Powder, just a powder.
Okay.
About 10 grams in your cup of coffee or in food, and you can have breakfast. And then we test every 30 to 45 minutes. And of course, any rise on this device of 4 units or more in the first 90 minutes means you have microbes, fecal microbes, living in your stomach, duodenum, jejunum, in the small intestine where they don't belong. And then we have to eradicate those microbes. Now, I've been taking a very different path. So I think Dr. Pimentel would argue you take Xifaxan or rifaximin. Well,
Right.
I've got some real qualms about that, because if antibiotics got us in this mess, can antibiotics rescue us? I have a hard time with that.
Right.
As you know, conventional antibiotics have a lot of problems, and the efficacy of Xifaxan is anywhere from about 55 to about 70%.
Well, and there's arguments about whether or not SIBO is caused by antibiotics. I mean, I tend to think they're a problem, but I don't think that is necessarily accepted by all the researchers.
Well, they haven't read the science then, because it's well established that you have loss of hundreds of. So if you took, let's say, one course, maybe a few days of azithromycin or clarithromycin, you kill off hundreds of species. That's well established. And then you have so those beneficial species, these are species like lactobacillus, bifidobacteria, fecalibacterium, akkermansia, lactospiraceae, ruminicaceae, eubacterium, clostridium. These are beneficial species. When you kill them, they were doing you a favor. They were suppressing the excessive proliferation of those fecal microbes. So when you lose those beneficial microbes, suppressing fecal microbes, the fecal microbes go berserk and they overproliferate. This is not my speculation. This is well established. I don't know why they'd say something as sadly ignorant as that. We know with good science that there's overproliferation of fecal microbes, E. coli, Salmonella, Campylobacter, Citrobacter, Pseudomonas, Proteus, that then ascend into the small intestine. Now, there's more to it, of course, but the science is not well sorted out. And how much of a role does glyphosate play, or other herbicides and pesticides? How much of a role do food preservatives play? Because they're antimicrobial in food, but also in you. How about things that emulsify the mucus barrier, like carboxymethylcellulose or polysorbate 80, or those things that emulsify the mucus barrier and thereby impair your protection against fecal microbes? There's a long list of things we're exposed to, but the science is clear. Antibiotics do mess us up. So it's been a century since penicillin was discovered. And in that, now, there of course, there are times you must take an antibiotic. If you have urinary sepsis or pyelonephritis, and you could die, you need an antibiotic. If you have pneumococcal pneumonia, you need an antibiotic. But what if you just have a dry cough, a fever of 100.4 from a viral upper respiratory infection? The impulse is, of course, here's an antibiotic. But the wild overuse of antibiotics, 650,000 prescriptions written every day. Over 1,300 prescriptions written every year for every 1,000 children. Wild overprescription of antibiotics. And that is with confidence one of the major reasons for why we're experiencing this. So Xifaxan would be, I think, Mark Pimentel's solution. And I really admire Pimentel's work. So this is not meant to be a criticism of his work. But I think conventional gastroenterologists, of which Pimentel is one, tend to revert back to pharmaceuticals and procedures. We know this, right? This is how conventional medicine works. So what if you took a probiotic, a commercial probiotic right off the shelf? Would that work to eradicate 24 feet of fecal microbes colonizing your small intestine? No. It might reduce bloating and diarrhea a little bit, but it won't get rid of all those fecal microbes. So I asked some different questions. I asked, what if we chose microbes that are known to colonize the small intestine? Most do not, right? Most colonize the colon, except for those fecal microbes that ascend. But what if we chose microbes that are known to colonize the small intestine? Very unique. and bacteriocins, microbes. So I chose three. These are three items: Rotari, a strain of Lactobacillus gasseri, and a strain of Bacillus subtilis. We ferment them because when you have trillions of microbes infesting the small intestine, and you come in with a probiotic with a few billion, you're not going to have any effect. So we're going to come in with hundreds of billions of microbes, and we do that by fermenting them as something that looks and smells like yogurt. It's not yogurt, of course, and you can't buy it in a store. We just want to get super duper high counts. So, for instance, if we took Lactobacillus rotari, small intestine colonizer, bacteriocin producer, we ferment it, rotari doubles. They don't have sex, right? Microbes don't have sex. They just double themselves. Well, rotari doubles every 3 hours at human body temperature. So we're going to ferment it for 36 hours, allow it to double 12 times. I perform flow cytometry on these yogurts, yogurt-like foods, and we get around 300 billion microbes per half cup or 120 milliliter serving. So we're going to ferment these microbes to get these super duper high counts. And so far, this has exceeded all expectations in normalizing breath hydrogen gas and or getting rid of or reversing the condition that we thought was due to SIBO and endotoxemia. For instance,
can you repeat those three microbes? You said Lactobacillus ruteri, and what are the other two?
So it's a strain of Lactobacillus rotari. I specify strain because, for instance, in Lactobacillus rotari, not all strains produce bacteriocins. So we choose.
Right. So which strain are we talking about?
So it depends. You'll have to edit this part out.
Okay.
I can't talk about products.
Oh, okay.
Because the FTC is watching.
Okay.
Because I have products, and those son of a bitches will come after you if you mention, I don't know if you know this, if you mention a product you're associated with.
Oh,
so,
really?
Yeah. They'll ruin you financially if you mention a product. Yeah. A lot of our colleagues don't know this. I've had colleagues who were financially ruined and sometimes had nervous breakdowns. Not so much the FDA. FDA does have some teeth, but it's the FTC. So I'm not being evasive. I'm not being squirty.
Okay. So a particular strain of Lactobacillus ruteri, and what are the other two bacteria?
Lactobacillus gasseri.
Okay.
And Bacillus subtilis. It looks like subtilis, subtilis.
Yeah.
If anybody read my super gut book, they'll say, oh, but your third microbe was Bacillus coagulans. And that was the original recipe. Well, what we found in our repeated measures of how many microbes we got, Bacillus coagulans, a fine microbe, by the way, just proved to be unreliable for fermentation in dairy. So I chose Bacillus subtilis. That's much more reliable. It's very easy to ferment. And we ferment it at 9 degrees Fahrenheit for 24 hours because it doubles every hour. It's much faster a reproducer. And it's a champion. The right strains are champions at producing bacteriocins. So what we're doing is we're bringing in microbes that colonize the small intestine where SIBO occurs and kill those invading fecal mites. Now, you might have to do this for a minimum of 4 weeks. It's not real fast. It's not like an antibiotic. And sometimes longer. So some people who have really bad SIBO, these are people who say things like, I took 3 years of antibiotics for Lyme disease or acne or some other reason. These people have terrible SIBO, and they might have to do it for months to get control of the darn thing. Now, the thing is, though, now I have 2 clinical trials, a pilot trial and a randomized trial, what's called a non-inferiority trial. We'll compare it to Xifaxan. But what I'm seeing anecdotally in hundreds, perhaps thousands of people is very impressive efficacy, though it may take some weeks to achieve that. But the other thing is, if I said, Dr. Weitz, we need to remove your small intestine surgically, you should say, well, hold on there, Buster. You better be damn certain that's necessary, right? But what if I said, what if the solution is something you make in the comfort of your kitchen that looks and smells like yogurt that you have with some blueberries and chia seeds that provides all these other benefits. We haven't talked about that. Those microbes, but specifically the Redefining and Gasterite to some degree, have other benefits on skin, bone, the immune response, musculature. So in other words, we're not saying do this and bite the bullet with all kinds of side effects. No, you do this, you enjoy it with your blueberries or whatever, and you enjoy all kinds of other health benefits.
So one of the keys to effective fat loss without muscle loss is curing SIBO using the right probiotics.
Yeah, but I wouldn't really call it a probiotic because you can't get this in capsule form.
Okay.
When we do the clinical trial, we will have to encapsulate it only because you can't have people making yogurt at home for a clinical trial.
Right. So very high levels of commensal bacteria. How about that?
Yes, exactly right. Yeah. Now, one thing we don't know, not just us, but the probiotic industry in general, does not have good evidence for what's called dose response. You know, if we were pharmaceutical people and we ripped people off for billions of dollars, we'd have the budget to run these we don't have that kind of budget. When we spend, let's say, $150,000, $200,000 for a clinical trial, that's about as far as we can stretch. We don't have the billions they can spend. For that reason, we don't often have a good sense for the number of microbes you need, but I think it's probably in the neighborhood of somewhere around 30, 40, 50 billion or more. And so you can appreciate that a lot of commercial probiotics, one of the problems, there's many problems, by the way, with commercial probiotics, but one of the problems is very low counts of microbes. So we're going to amplify it cheaply, comfortably in your kitchen with this thing that looks and smells like yogurt. And by the way, that all the recipes and where to source the microbes are in my books, like Super Gut and Super Body. I tell you where to buy them, how to ferment them, some of the devices you can use, like a yogurt maker or a sous vide. A stick sous vide is another good one. Or some people like to use their Instant Pot. It's very easy to do. Now, that's just SIBO and endotoxemia. There's other things you can do. So one of the things that people need to address is their insulin resistance. And as you know, 2/3 of the country has insulin resistance. And insulin resistance, your body's unresponsiveness to insulin.
Could you start up again with?
So you who are active have a fasting insulin level of 1. Uh-oh. I think we're back.
Yeah. Could you start up again with insulin resistance?
Insulin resistance, because insulin resistance is a phenomenon that adds to belly fat, abdominal fat. And so, and that's 2/3.
And that's because you end up with high insulin levels that stimulate fat.
Yes. So
fat storage.
If we took somebody who was slender and active and had insulin sensitivity, their fasting insulin blood level would be something like 1 or 2 or 3 microunits per liter. We take somebody who's got insulin resistance and abdominal fat, they have levels of 50, 100, 150. In other words, it's not 10% worse. It's 30-fold worse. It's 50-fold worse. It's 100-fold worse. And that level of insulin causes expansion of abdominal fat. It also damages muscle. So we're going to reverse insulin resistance. Well, how do you do that? Well, you stop eating foods that trigger insulin, wheat, grains, and sugars, not fat, wheat, grains, and sugars. And then we address common nutrient deficiencies that, when you're deficient, allow insulin resistance. When you restore them, they synergize to minimize insulin resistance. Very common things: vitamin D, omega-3 fatty acids, magnesium, iodine. Put them together, because these are largely absent from modern diet.
When you talk about avoiding grains and sugar, Are you eliminating all complex carbohydrates?
No, but so with grains, they're the ones that contain the amylopectin A carbohydrate unique to grains, which is a flagrant trigger of blood glucose, of insulin, and by the way, also of small LDL particles, the real cause for coronary disease, for heart attack. Heart attack has nothing to do, heart disease, nothing to do with LDL cholesterol, total cholesterol, statin drugs, saturated fat. That's all fairy tales. They came from outdated science from the 1950s and 1960s, but it still persists because it made pharma $1 trillion. So that fiction persists among many of my colleagues, and they've ignored the science that tells us that it's the amylopectin A of grains, as well as glucose, sucrose, and fructose, that triggers formation of the real cause of heart disease, small LDL particles.
So you're okay with, for example, legumes, potatoes, other grains like quinoa?
So we do, because so many people are insulin resistant. And that means I'll have sky high blood glucoses, even with something like quinoa, that we do impose, or I do suggest, at least a net carb limit of no more than 15 grams net carbs, so that you don't trigger high blood glucose, don't trigger high blood insulin, don't trigger glycation, glucose modification of proteins, which is irreversible, and don't provoke formation of small LDL. This
So 15 grams of complex carbs a day?
Net carbs, total
net carbs,
fiber.
That's a very small amount. Yeah.
We're not ketogenic. You may be intermittently ketotic, but we're not purposely ketogenic. But I may be kind of militant with the small LDL issue, because I came from a world where people were dying of heart attack, sudden cardiac death, survived resuscitation, got bypass surgery, went through multiple stent implantation. In other words, heart disease is a dangerous thing.
Right.
And what's so
the number one killer in the United States and around the world.
And it's shocking how easy it is to provoke formation of the real cause of heart disease, small LDL particles. So here's an example. Somebody would say, I'm a survivor of sudden cardiac death. I got CPR resuscitated. They opened up 2 of my arteries in the cath lab, or I had bypass surgery, whatever. And we do their lipoprotein testing, like usually NMR, nuclear magnetic resonance lipoprotein test, which has been around for over 3 decades. I've been doing it for 30 years. And they would have something like 2,400 nanomoles per liter, particle count per volume of small LDL. And so I'd say, listen, John, you got to eliminate wheat, grains, and sugars, the triggers for small LDL. He does it. It drops from 2,400 maybe to 800. So dramatically better, but still bad. We're aiming for less than 200, or preferably 0. And I say, are you sure you're doing the diet and your omega-3 fatty acids, vitamin D, magnesium, etc.? Oh, yes, I am. I say, you sure? He says, well, every Friday I allow myself 1 slice of pizza. It's my bad day. But here's the thing. Small LDL particles, there's small conformation, are not recognized by the liver, because the recognition protein, the apoprotein B protein, is not recognized by the liver, because when the LDL particle is small, the apoprotein B recognition protein is partially concealed, and the liver can't see it. And so while a large LDL particle by consumption of fats and oils is rests for 5 to 7 days. And it goes around and around and around in your circulation, giving it lots of opportunity to enter the wall of your arteries. And
this is an interesting point. I heard you make this before. Most of the time when integrative cardiologists I know talk about small, dense LDL being more atherogenic, they talk about the fact that the smaller particles are easier to penetrate through the endothelium. But you're emphasizing the fact that they last a longer time in the bloodstream as well.
Mhm. Oxidation. They're also more adherent to the structural proteins in the walls of arteries, like proteoglycans. They're also more inflammatory. They're more likely to trigger a cascade of inflammation in the arteries. In other words, this little bastard is perfectly crafted to cause coronary disease, and it's caused by a diet low in fat and rich in healthy whole grains. But that is the state of affairs in prevailing advice. But anyway, so,
And
so
do you
that
think that
reason,
saturated fat has any role to play in this or not?
not a primary role. So the reason why saturated fat has something of a role is, so if I consume saturated fat, it doesn't trigger formation of small LDL, because the liver process of forming small LDL starts with the amylopectin A carbohydrate or other sugars, glucose, sucrose, fructose. That the liver is very good at converting sugars to triglycerides. Triglycerides are fats. Fats are triglycerides. That process is called liver de novo lipogenesis, the creation of new fats.
Right.
So I eat the amylopectin A of grains, it's converted to triglycerides. Now, triglycerides are fats, but they can't circulate freely in the bloodstream because fats would coalesce in the bloodstream, just like salad dressing. Even if you shake it, it will separate into oil on top, vinegar and water on the bottom. The oils coalesce. Well, if oils coalesced in your bloodstream, they would block you would die within moments. So fats need to ride on an aqueous soluble protein. So we call these lipoproteins that contain the triglycerides, but they're also made aqueous or water soluble by those proteins, like apoprotein B and others. So the liver knows this, and it packages those triglycerides created via liver de novo lipogenesis into very low density lipoproteins, VLDL. Low, just like salad dressings, low density floats to the top. So VLDL, very low density. And VLDL particles themselves are a flagrant cause for coronary disease. So that started with your consumption of grain sugars and sugars. And the VLDL particles interact with LDL particles, make LDL particles triglyceride enriched. And then there's a series of enzymatic steps involving enzymes like lipoprotein lipase and hepatic lipase that cause that LDL particle to become small. And that's where you have what you're talking about, particles small enough to penetrate the walls of arteries, prone to glycation, oxidation, inflammatory, adherent, and persistent for extended periods in the bloodstream. So, and this is not my speculation. There are 55 clinical trials that have established that measurement of small LDL is dramatically superior to LDL cholesterol. Why isn't this talked about more? Because there's no drug for it.
Right.
So, in other words, if the treatment is something you can do in your kitchen and it's free, well, there's no pot of gold. There's no pharma who's going to send in this sexy sales rep with a miniskirt or a three-piece suit. No one's making a ton of money, so why talk about it? And
right. It's the same reason why they don't test lipoprotein A.
Yes, there's no drug for it. That's right. Exactly right. They're trying real there'll
be several drugs out in a few years, and then everybody will get tested for it.
Yep. So, but the small LDL, and of course, in lipoprotein A is a molecule for your listeners that has, in many people, very high cardiovascular risk. Well, the lipoprotein A molecule has two parts, has an apoprotein A protein and an LDL particle. And it's when that LDL particle is small that makes the lipoprotein A total molecule much more dangerous. We say atherogenic, likely to cause atherosclerotic plaque.
Wait a minute. So there's actually two types of LP little a's?
No, there's two parts to it.
Oh, okay.
Lipoprotein A programmed by your liver. Then there's the LDL particle, and they're bound together. And when
but are you saying you can have lipoprotein A particles that are less or more dangerous?
Mm-hmm. Yeah, that whole notion got started with a study called a little crazy study called the Lugalawa study about 20 years ago. It was a study of all things of Bantus in Tanzania. And there were two groups of Bantus. One group lived on Nyasa Lake, which is an inland lake in Africa, teeming with fish. And they would eat fish for breakfast, lunch, dinner. And they had a group of related Bantus living further inland. There's no cars, no internet, right? And they would live too far from Lake Nyasa to eat fish every day. But there's a lot of intermarriage. And they all had, there's a very high preponderance of lipoprotein A. Well, interestingly, this was Dr. Santika Markovina's studies from University of Washington. He showed that the Bantus who consumed vigorous intakes of fish had very different lipoprotein A molecule structures compared to the non-fish eating Bantus, including a much less dangerous form of the apoprotein A and a larger LDL particle. So since that, no one's done the prospective study, that is eating a lot of fish, or what it proved to be due to the omega-3 fatty acid intake. And the estimated intake in the Bantus living on the lake was 5,000 milligrams EPA-DHA per day. So we've been using 6,000 milligrams to be safe, and it has worked. It has stopped progression of it hasn't caused regression of coronary disease like we achieve in non-lipoprotein A people. But in people with lipoprotein A, we see atherosclerosis stop progressing by doing what we call high dose omega-3 fatty acids, based on the Lugolawa study from some years back.
Interesting. That's fascinating.
But long-winded answer to your question about why we limit net carbs, because I saw people die from eating grains and sugars and provocation of VLDL, small LDL. And this, I mean, it's sometimes easy to forget. This is a dangerous disease. People die. And so we're not talking about, high cholesterol. 80 million Americans take a statin cholesterol drug, and there's been no meaningful reduction in cardiovascular risk. That's why your local hospital probably spent $80 million to add a new cardiovascular wing on, because that's how they make money. Heart disease remains the number one moneymaker for hospitals and healthcare systems and my colleagues, and it's wrong. If we didn't have the science, that'd be different. But there are now 55 clinical trials showing that small LDL is a markedly superior marker for risk for coronary disease. And it's caused by wheat grains and sugars, amplified by insulin resistance and endotoxemia.
All right. So getting back to weight loss. So the proper way to lose body fat without losing muscle is not to do low calorie dieting, not to do tons of exercise, but to reinforce your microbiome and get rid of SIBO, and eat a low carb diet. And then what's the other wing? You recommend incorporating certain supplements to put back in nutrients that we're missing in a modern diet?
Exactly. So what we're talking about, we're not talking about treating things with drugs and we're talking about restoring things that you and I and your listeners should have had all along. So you should have had reuteri, lactobacillus reuteri, all along from your mom at birth. But either she or you got antibiotics somewhere along the way and killed all your reuteri. Likewise, gastri. So we're just restoring microbes that you should have had all along. The diet, we're restoring a diet that you should have been on from birth. You should have been on this as ancient people were, something similar to their diet. We're also—
You mean they didn't have Pop-Tarts back in caveman days?
So another big, of course, error that's been made in modern lifestyles is we were told to cut our saturated fat and total fat. Well, that caused most people to abandon the consumption of organ meats, and to some degree meats in general. And so two factors lost by that, and loss of consumption of organ meats, is consuming collagen and hyaluronic acid. So collagen rich in tough cuts of meat and organ meats, of course. Well, collagen by itself reduces abdominal visceral fat and increases muscle, as well as the ladies love it because it increases dermal collagen and reduces their wrinkles, And it also adds to joint collagen, joint cartilage, collagen. Cartilage is 70% collagen, of course. So collagen, yet another factor lacking in modern life that people have not been getting, but when restored has wonderful effects on what I call shape and body composition. Likewise, hyaluronic acid. Ladies always say that they say, don't talk about hyaluronic acid because I buy $150 a month serum and I put it right here. They say it reduces my crow's feet. I say, well, what's it doing for the skin as it's taken orally? It's one of the rare fibers that comes from animal. So
wait.
Again,
Can you start up again because we lost you again? You were just talking about hyaluronic acid.
Okay, so another factor missing from modern diets is hyaluronic acid. Now, ladies always say to me, we know all about hyaluronic acid because I put my serum right here and it reduces my crow's feet. So I asked them, what did it do for the skin on your neck or abdomen? Nothing, of course. So the real power of hyaluronic acid is consumed orally, as you would have had you been eating brain or skin or other organs. And hyaluronic acid is one of the most underappreciated fiber. It's a fiber. It's a rare fiber that comes from animals. So what happens when you consume hyaluronic acid orally? Well, it does increase dermal collagen. So ladies have reduced wrinkles. It causes retention of moisture in the dermal layer. So ladies love the plumping effect you get from it. It also contributes to more collagen in your joint cartilage. It increases the synovial fluid, the cushioning fluid, or the lubricating fluid in your joints and your hips and knees. So skin, joint, it also is important probably for arterial health. The arteries are lined with something called a glycocalyx, finger-like projections that control the tone or relaxation of arteries. Well, what's the glycocalyx made of? Hyaluronic acid. How about a woman's reproductive health? The uterus, cervix, and vagina are made largely of hyaluronic acid. And we know that as women age, particularly into their mid-60s and onwards, they struggle with vaginal atrophy, dryness, discharge infections, candida, bacterial infections, etc. Well, part of the solution is restoration of hyaluronic acid. But there's another layer to hyaluronic acid because it's a fiber. It provokes the proliferation of beneficial species in the gastrointestinal microbiome. These are species like Faecalibacterium, Akkermansia, Clostridium species, Eubacterium species. These are species that produce the fatty acid butyrate. And butyrate, produced by those beneficial microbes, goes to muscle and improves muscle mass and insulin sensitivity. In other words, hyaluronic acid, this fiber absent from modern diets, has so many underappreciated benefits. So we restore. Now, ideally, you eat organ meats, but most people say, yuck, I can't do that. So we take these things as supplements.
Do you consume organ meat?
I do, but I have to say I can't bring myself to eat brain or heart. So
Yeah.
what a lot of us do are things like this. Cut your ground beef like 50-50 ground beef, a ground liver. I've had pancreas, I've had kidney, but it's tough for modern people. And it's really tough to even get it because I went to a butcher. I wanted to get some beef hearts. Over time, maybe 30 years, it'll get a little easier. But right now, it's a little bit tricky.
Yeah, I've tried eating beef liver a number of times, and if you get it cooked just right, it's pretty good. But if you miss it, if you over or undercook it, it's not good at all.
But you can see the theme here is to restore factors or practices that are largely absent from the lives of modern people. And because, if we went to equatorial Africa or the highlands of New Guinea or the Amazonian rainforest in Venezuela or Bolivia, we would see slender, muscled people. And they don't take Wegovy. They don't have gastric bypass. They don't count calories. They don't count fat grams. They don't go to the gym for an hour or two, 6 days a week. They just live. And yet they have heavily muscled, sinew-like limbs. They're slender. They have virtually no insulin resistance. And by the way, of course, no hypertension, no coronary disease, virtually no dementia, rare cancers, no colon cancer, no hemorrhoids, no constipation. Psychiatric issues like anxiety and bipolar illness and schizophrenia are exceedingly rare. In other words, they don't have what anthropologists continue to call the diseases of civilization that we have.
Yeah, but they don't have to go to the gym because they're acting physically all day long. They're catching their food, they're preparing it, they're doing physical things all day long. They're not sitting in a chair at a computer, in a car, in a hotel room, all those things. They're not eating processed foods. They don't have the ability to eat too many calories because food is scarce. They're not being exposed to the toxins we get exposed to on a regular basis. They're not undergoing the stresses we have in modern life. So,
see, in an ideal world, Dr. Ben Weitz and his listeners will all go to the Amazon rainforest and spend a couple of years there. But of course, no one's going to do that. So what we're doing, in effect, is trying as best we can in a modern life with smartphones, with nice cars, with air-conditioned homes, et cetera. We're going to try to mimic, at least take some lessons from that experience.
Right. So the way to lose fat, and especially you emphasize the importance of visceral adipose tissue, and then there's another type of fat that you describe, which is fat contained in organs or around organs.
Yeah, so-called ectopic fat. That's right. So as people are expanding their abdominal visceral fat, that is fat that encircles the abdominal organs, like intestines and liver, et cetera, in parallel, the body starts to deposit fat in odd locations around the heart, so-called epicardial fat. And that accelerates the development of atherosclerosis. It deposits fat in your joints like hips and knees. You can actually see it on an MRI. And when you have globules of fat in your hips and knees, it accelerates the degeneration of your cartilage and it gets you faster to bone-on-bone arthritis. If you deposit fat in your pancreas, it accelerates the death of beta cells and can convert a type 2 diabetic into an insulin-dependent type 1 diabetic. But you also deposit, of course, in muscle, so-called myosteatosis, that thereby reduces strength. We haven't talked about that. So, yes, we all lose muscle as we age. We make it worse with the accumulation of visceral fat that results in myosteatosis that further erodes muscle mass and strength and reduces myokine production. That is, these mediators of multiple beneficial effects. And so at multiple levels, we have screwed things up. So that's ectopic fat. Now, the crazy thing is, all those conventional methods of losing weight we talked about, reducing calories, bariatric procedures, and pharmaceuticals, are selective for loss of subcutaneous fat, that is fat below the skin. That's not as much of a problem. It may be an aesthetic problem, like if you have too much fat in your buttocks or thighs or neck or chest, but it's not really a metabolic problem like abdominal and ectopic fat are, because those are the sources of insulin resistance, inflammation, and the driver of ectopic fat and myosteatosis. Subcutaneous fat is an aesthetic issue, but it's not a metabolic issue. And those methods to lose weight are all methods that preferentially cause loss of subcutaneous fat and thereby limit the benefits you obtain, the metabolic benefits you obtain. Of course, the stupidest thing of all is liposuction, because you can't enter the abdominal cavity you're going to be content with just removing subcutaneous, the least bothersome form of fat. So time and again, conventional healthcare got it tragically wrong. And with all those methods, they're shortening your life. They're accelerating your visit to the assisted living center. They're accelerating your reliance on scooters, walkers, crutches, arthritis, joint surgery, falls, fractures, frailty, loss of independence, sarcopenia, dementia. This is what the healthcare system is doing to us.
There's at least one study showing that GLP-1s reduce fatty liver.
Yeah, there's no doubt that GLP-1 agonists do cause loss, so they're selective for subcutaneous fat, but you still do lose some abdominal visceral fat and other collection of fat. So fatty liver would be one form of ectopic fat. So you lose some of the epicardial fat around the heart, you lose some of the fat infiltrating your pancreas, you lose some of the fat that accumulates, what we say, the hilum of the kidney, where the arteries and veins enter the kidney. So there's no question that they do this. When you stop it, though, it all comes back.
Right.
Vigorously. It comes back worse than it was at the beginning. And so you pay and you put thousands of dollars into the pockets of pharma. Right. And so we're talking about tens of billions and probably hundreds of billions in coming years. And yet you're going to die several years younger. But the gravity of all this, I don't think you and I can overstate just how important this is, that people in healthcare, the healthcare industry, are making billions of dollars while you pay the price in your accelerated disability and your accelerated death.
So losing weight the wrong way leads to a shortening of your life.
Isn't that something? And we have that now with huge databases. Now, lots of details need to be worked out. And one of the things I haven't mentioned is, I call the hormone oxytocin. So people recognize oxytocin as the hormone of love and empathy, and it is that. But there's preliminary animal evidence, and we've been working on trying to corroborate the human evidence, that you can boost oxytocin also. We do so primarily with restoration of the lost microbe Lactobacillus reuteri that sends a signal via the vagus nerve to the hypothalamus in the brain to release oxytocin. And if we believe the experimental evidence, there's a dramatic return of youthful muscle. There's selective reduction in abdominal fat. There's a reduction in so-called hedonic eating, that is snacking behavior. You lose your interest in snacking. I should make mention of that. One of the things that happens with this collection of strategies is a dramatic reduction in appetite. So you'll never hear from me, cut your calories, smaller portion size, move more. You'll never hear that from me. Instead, we're going to go wheat and grain free. In addition to losing the amylopectin A, you're also losing the gliadin protein that is inefficiently digested by humans because we don't have the enzymes for it. And the gliadin protein of wheat is broken down into 4 or 5 amino acid long peptides that act as opioids on the brain and stimulate appetite. So the gliadin-derived opioid peptides are a very potent appetite stimulant. When you get rid of wheat grains, you don't have gliadin-derived opioid peptides driving appetite. So appetite drops dramatically. We don't limit fat. Fat's satiating. We use more butter. We use more extra virgin olive oil. If you're going to have a ribeye steak, eat the fat. Don't worry about the fat. And then lastly, we provoke oxytocin that has that suppression of hedonic or snacking behavior. So what happens to people doing this is you almost have to remind yourself to eat. People will have their breakfast, say, of maybe a couple of eggs with some sausage, hopefully something fermented as well, by the way, that's important. And then maybe it's 3 o'clock, 4 o'clock. You forgot to eat lunch or you had a little something. So a lot of us have reverted back to kind of a 2 meal per day pattern, maybe at breakfast or early or late, and then maybe a second meal. And that's it. We're not because we're trying to limit calories, but because you're no longer hungry. And by the way, hunger feels different also. The hunger we see in average Americans is this uh, violent kind of that people call it, I think they call it hangry, right? We want to knock people out of the way to get to your food, or you're getting mad at the waiter or waitress because it took more than 10 minutes to deliver your order to the table. That all goes away. You can cruise through your day. And so people who are interested in such things as time restricted eating or intermittent fasting, these kinds of things become much easier because you're no longer plagued by this ravenous hunger anymore, this desperate hunger. It's all gone. Hunger feels more like this, I'm a little restless. Could that be hunger? Very different.
Great. So I think we're pretty close to wrapping. Any final thoughts, other things we haven't covered?
So, I feel strongly about this because,
Yeah.
if we're talking about just dropping your listeners dropping a couple of dress sizes, okay, yeah, sure, great. Or just reducing blood glucose. No, we're talking about not falling into the trap set there by many of our colleagues, certainly by the pharmaceutical industry and other industry like the bariatric surgery industry, who are not doing you any favors. They look like you're doing favors, but shaving several years off your life, that's no favor. Increasing the likelihood you end up in an assisted living center, using a walker, falling, losing independence. These are not favors. That's the crazy thing. It doesn't have to be that way. If all we do is draw from the existing science and use some logic and rational thinking and reject the nonsense, the fictions of the last 70 years that got us into this global mess, and we pay attention to what fat you're addressing, what foods are doing to you, what nutrients are lacking in modern life that influence factors like insulin resistance, restoring microbes that are lost that play a big role in the gut brain and gut muscle axis, getting rid of this infestation of fecal microbes in the small intestine. Like cortisol, we haven't even talked
Wait,
about that.
Yeah, right.
Now,
You were just about to say fecal microbes, and then you cut off.
I forgot. So we're going to set right what's going on in your gastrointestinal microbiome
Okay.
and other factors. And of course, if you go through, by the way, if you have a bariatric procedure,
Yeah.
let's put aside the major increase in suicide. That is very underreported. There's a huge increase in suicide after. It's not quite clear why that
But
is.
don't people get bariatric surgery and almost immediately their diabetes goes away?
It does from the weight loss until it comes back because they lost muscle.
But
And
doesn't the diabetes go away like the first week before the weight loss?
it can, but there's going to be the consequences of sarcopenia, of loss of muscle, the regain of fat, mostly in the abdominal region, the abdominal visceral fat, and at least 50% of people after bariatric surgery develop SIBO and thereby endotoxemia. And so a lot of this is underreported. A lot of the studies performed to support the use of bariatric surgery are performed by my colleagues who are supported by the manufacturers of the devices used in bariatric surgery. In other words, what's worse than the pharmaceutical industry? The medical device industry. They are bigger and more powerful. You don't hear much about that. But a lot of those studies supporting the use of bariatric surgery were performed by people who are, in effect, paid by the industry that manufactures the devices that support that industry. Meaning that you really can't rely on a lot of the reported data. In my experience, bariatric surgery is a lot worse than you think it is. This really got driven home for me when I had a 44-year-old woman who wasn't that overweight. She was maybe 178 pounds, 180 pounds, something like that. And I counted her on how to lose the weight. Diet, nutrients, etc. But she couldn't do it. She was kind of an addictive personality, just could not do it. So she decided, I'm going to go through bariatric surgery. And I said, I don't think it's a good idea, but she did. She was found dead on her kitchen floor after surgery by her son, like maybe a couple of years later. very traumatic for the son. This is underreported. There's a lot. It's a lot worse than people think. The increase in suicide, in this case, it wasn't suicide. It was, I don't know why she died. There was no autopsy. Um, in other words, the conventional pediatrics front benefits look spectacular. The long-term consequences are terrible.
One more thing I wanted to point out: you also recommend putting back in not only the probiotics, the commensal bacteria, and the collagen and the hyaluronic acid, but you also recommend putting back in carotenoids, which have been lost.
Yeah, so carotenoids, as you know, underappreciated: beta carotene, lutein, zeaxanthin, cryptoxanthin, astaxanthin. These are, of course, components of food, natural components of food. My favorite is astaxanthin. It's the orange or pink in salmon or shrimp or lobster. Only because the carotenoids have all kinds of wonderful effects, largely anti-inflammatory effects. Because a lot of what we're talking about, of course, insulin resistance, endotoxemia. A lot of these are driven by inflammation. A lot of the adverse effects are driven by inflammation. So while we don't treat inflammation, we restore factors that are largely absent from the diet. That among their benefits is suppression of inflammation. There's been this conversation of so-called inflammaging, that is the known increase in inflammation that occurs just with aging. Well, the astaxanthin and other carotenoids have been shown to have dramatic effects on reducing inflammaging. So we also add carotenoids. Now, it could be beta carotene from a red pepper. It could be other citrus rinds and other healthy foods, or it could be the astaxanthin. Now, because as you know, we don't have the luxury of eating all the fish we want because of mercury, nor all the crustaceans or shellfish we want because of cadmium and mercury. And so in many instances, we have to resort to some degree to supplements because it's just become hazardous to eat fish and other things from the sea. So that's one of the options people have to get their astaxanthin or other carotenoids via supplements to compensate for the dangers, sadly, of modern food.
Yeah, and really probably the whole category of phytonutrients, not only carotenoids, that have all these remarkable health benefits.
Yes, including microbiome benefits. So we know with good science
polyphenols for the microbiome.
Yes. Yep. So all we're doing is restoring things lost.
There you go. All right. So how can listeners and viewers find out more about you and get more access to your programs that you have to offer?
So a lot of this is laid out in the new Super Body book.
Right. So pick up Super Body, which is available wherever books are available, right? Barnes & Noble, Amazon, etc.
It's the Super Gut book, its predecessor, that lays out a lot of these recipes, that takes the microbiome issue a little further. So if you said, well, if you were a woman and said, I want to have a reduction in some of my menopausal symptoms, or I'd like to reduce some of the agony of menstrual cycles. Well, how about Lactobacillus gasseri? Or if you had vaginal atrophy, dryness, and urinary tract infection, let's restore Lactobacillus crispatus. If you have a newborn baby and you want to ensure neurological maturation with a higher IQ and better health later on, let's make sure that child has Bifidobacterium infantis. And we can get these microbes and we can ferment them as yogurt or other foods. So that's in the Super Gut book. I have thousands of blog posts at my WilliamDavisMD.com. I have my podcast also, Define Health, as well as I have a membership site where we do this. Typically, once a week, we have a meeting with a bunch of people, usually 100 plus people, and we talk about these things. People say things like, I tried to make roti yogurt, it didn't turn out, it's separated. We talk about why that could occur, or fungal contamination or mold contamination of yogurts. All the little nitty-gritty details, we talk about it to help people work out the problems.
That's great. And so what is your contact information?
So the blog is williamdavismd.com. The membership website has an awful name. It's called innercircle.drdavisinfinitehealth.com. Of course, Facebook, Instagram, all that stuff too. YouTube is a YouTube channel too.
Right. What's your YouTube channel? WilliamDavis.com or what?
If you put, Dr. William Davis, it'll take you to the.
Okay. That's great. Excellent. Thank you so much, Doc.
Thank you, Dr. Weitz. Keep up your great work.
Thank you for making it all the way through this episode of the Rational Wellness Podcast. For those of you who enjoy listening to the Rational Wellness Podcast, I would very much appreciate it if you could go to Apple Podcasts or Spotify and give us a 5-star ratings and review. As you may know, I continue to accept a limited number of new patients per month for functional medicine. If you would like help overcoming a gut or other chronic health condition and want to prevent chronic problems and want to promote longevity, please call my Santa Monica Weitz Sports Chiropractic and Nutrition office at 310-395-3111, and we can set you up for a consultation for functional medicine. And I will talk to everybody next week.